everyone. Thank you for having me at this conference. My name is Alice Yao. I'm a plastic surgeon specializing in reconstructive microsurgery in New York City. I work at Mount Sinai Hospital. It's actually recently become the largest non-government health network in New York. So you've heard already a lot of the challenges with starting a new procedure in an established field. So I'll just go over briefly the steps that I've had to take to navigate this in New York. Okay, so the first step was easy, actually. I was fortunate enough to have trained at MD Anderson for microsurgery. I trained under Jesse Selber, who, as we heard from Dr. Juan Carlos's lecture, was the crazy nut. I am merely one of the followers trying to get this procedure to look less crazy. So thank you. So after training, I went ahead and went to New York City, where I started my first job, essentially. The first thing I did before even having any patients who I could perform this procedure on was try to convince the hospital that I was a robotic surgeon. I figured if I first started and got them to believe this, then I wouldn't have to convince them later. So actually this was worked to my advantage because there was no preset protocol. Like for urology, they have to have 20 proctor cases, they have to show skills in maybe 20 different criteria, but no one could proctor me. So they just came up with these 3 criteria where, of course, I had to get the intuitive certificate online, which I found quite easy. It was time consuming, but I think anyone can get through it. And then I submitted my case log from fellowship, as well as a reference letter from Dr. Selber. So they gave me my credentialing, surprisingly, and then I used that to my advantage, even though I hadn't done any cases yet. And the other hospitals I worked with, I just said, well, Mount Sinai credentialed me, so you should as well. So using this strategy, I was able to be credentialed at all the hospitals I work at, actually. This was before I even did any cases. So moving on, so once I found my first robotic patient, I went ahead and started going through some of those difficulties that everyone else talked about. The urologists have 3 robots at our main hospital, and they really monopolize them. So it was a little difficult to get OR time. So I had to make friends. The first person was the chairman of urology at my hospital, who uses the robot, 2 of them himself. So, you know, I went to his cases, I scrubbed with him. He didn't let me do any operating, but FaceTime is extremely important. So after that, then I became friends with the OR scheduling manager. And let me mention that this friends part is not that easy because none of these people want to be friends with you. So you just have to really smile and spend a lot of time with them. And then finally, once I got my case on the schedule, then I had to go talk to the nurse manager for the robotic team to make sure that we had good rapport, that she would get the instruments. And of course, a key strategy here is to not tell them, you need to do this for me, but to ask them, make them seem like you're requesting a favor from them. I asked her, can you help me make this better? You're more familiar with the robot than I am at this time. So that worked out very well. So the case was smooth. I'll show you the example of my first case. This is a very healthy 50-year-old woman who had prior pedicle tram reconstruction for breast cancer on the left. She had radiation therapy afterward, so you can see it became quite atrophic. Her biggest complaint is that she can see the rib contour. That's not the button I try to press. Okay, you can see the rib contour. She also refused an implant and really did not want another donor site. So she was actually quite a good candidate for a robotic assisted latissimus. I won't belabor this much because Dr. Selber's published many papers on this, so you can read about his technique, but briefly, here's some photos, markings. You can see that it's a very small access incision to the pedicle of the latissimus plus port incisions. Okay, just some details. Here we are in the operating room. Bed is extended so that we can have access to the port sites. We use 3 ports. I do like the 4th port for suction. Here we are all set up. Anesthesia looking quite bored because it took us so long to set up. And here are the ports and the assistant. So, intraoperative photo. And here we go. I got it done. Moving it to the front. And then the final outcome. This is 3 months post-op. The patient herself is very happy. I would have preferred to use an implant myself, but we do what the patient wants, so she no longer has any evidence of the rib dimpling. And she's very happy with her donor sites, minimal. So, moving on to the next step, you don't just finish there. You have to kind of broadcast your procedure and hopefully get more patients from that. So I work very closely with the marketing team. This actually is tougher than I thought. I thought they would just write a big press release and make me look good, but that's not true. We actually haven't even gotten to the part where we published anything yet. They want to simplify all the indications. They want to get a really good common language for how this procedure works. And then finally, they did not like my patient. My patient was a little bit private, did not want to share her name or the details of her procedure. They want another patient that is someone who likes social media, who wants to be on television, so that they can make a video of it. So we will get there. It will be published and you'll probably hear about it eventually, but we'll have to wait for the next step. Okay. And then future plans. So now I have credentialing at the trauma hospital, so I do lower extremity reconstruction as well. So hopefully we'll start doing robotic assisted microsurgery, free flap transfers. And I've also been talking to many of the other services I work with. So one of the breast surgeons I work with is very interested in performing robotic mastectomy. So I look forward to hearing some of the other lectures here and maybe pursuing that with that team. Also, general surgery is starting to do more and more robotic procedures, so I've offered my assistance in doing any sort of reconstruction that they may need. And finally, of course, training residents. So in the US, actually the plastic surgery programs do not teach robotic assisted surgery. So my residents are very excited to start learning. We do have a Da Vinci training robot, which I'm on in our hospital, so I will be incorporating that into my program. That's it. Thank you for your time. This is my hospital in Central Park, so I invite you all to visit.